Firstly, it's good to be in Brisbane. I left Melbourne the other morning and it was 2 degrees when I got up, so I'm happy for the warm weather. And the lovely city, it's great. I went for a walk along the river last night and was in a t-shirt. Everyone else is in hoodies and jumpers, but I think it's great. I'm kind of fortunate, I think, to be the last in this session because a good background has been built, so the hard work's been done, and I'll just kind of bring this back to a service level. Talk about dual diagnosis in older adults. My project in a Melbourne older adult mental health service, what I call the Great Divide. Yes, I confess, I'm a mental health nurse, but I did actually work for Peninsula Health Service, drug and alcohol service that Professor Roche was talking about, that caters to people 60 and over, and I'll talk about some of the lessons I learnt there and the implications for services as we see a bigger ageing population. So what's dual diagnosis? I'm sure you all know, but I just presented this in Seattle in March and an experienced psychiatric nurse said to me halfway through, "What are you talking about? What is this?" So really it's co-occurring mental health problems and substance use disorders, but the reality of it is that it's much more complex. And in the literature review for my PhD, I discovered that it is very much more complex. It is a number of factors really, predominantly based on mental illness and alcohol and drug use, but complex medical conditions which are rife in this cohort. When I say older adult, our service deals with people 65 and over. We do take a few late 50s, early 60s, but generally they have to have what are considered age-related issues. The stigma of mental illness and substance use, which has been shown through the literature as a barrier to help seeking. Social isolation. A lot of our consumers of the mental health service are quite different from the AOD service in that they have long-term involvement with public mental health services. They're generally poor. They generally live in public housing on their own. And this other little interesting thing that I found in the literature, adaptive substance use. Levi and Anderson in 2005 did a study having a look at this concept of people changing their use in changing drug markets that have become more violent. These older people felt pushed to the margins, and there's also a little bit of work around people that switch their use from illicit substances to prescribed opiates, benzodiazepines. They don't often get them prescribed, of course. So just to kind of bring this back, older adults have generally been thought to mature out of their substance use. In 1962, Charles Winnick had a look at this and he sounded like a bit of a go-getter. He hung out with a lot of jazz musicians who, through their 20s, used a lot of heroin and then gave it up in their 30s. So he basically looked at the data from people who were arrested by the Federal Bureau of Narcotics in the States and found that a vast majority of people stopped their use of their own accord. He said that social pressures, vocational pressures eased and people generally stopped. There's been successive work trying to replicate this and they never got to the lofty heights of his 67%, I think he found. And just to go back to this adaptive use, older adults with long drug use careers adapt their use to substances and levels that their ageing bodies can handle, or they're easier to obtain in that changing, more violent drug world as they described it. Also, and again, I'm very fortunate to be presenting last because this has been covered, we're seeing people live into long age, and a lot of this has been credited, particularly in drug users, to needle and syringe programs, harm reduction, substitution therapies. But of course, there's advances in medical treatment that are helping Joe Hockey realise the goal of seeing us all to live to 150 and probably work till 120. I apologise for bringing this back to mental health, but I think you guys in drug and alcohol, well, in Queensland, you're both way ahead. You're coming back to an integrated model, but in Victoria, we're very much split, and you guys, I think, are ahead of the game when it comes to assessing. So in Victoria, we have just had a new Mental Health Act, which is very much recovery focused. And one of the principles of this Mental Health Act is that people have their drug and alcohol use addressed. And this came out of the Chief Psychiatrist report in Victoria, which found a lot of people were put into mental health treatment, inpatient treatment in a coercive fashion, and basically their drug and alcohol needs were ignored. So of course they suffered withdrawal symptoms and often escaped, for want of a better word, out of secure mental health units, took drugs, overdosed and died. And there are a huge number of these cases that the Chief Psychiatrist had discovered, and it was always the same thing, people withdrawing, taking off from the ward, taking drugs and dying. So that's why the principle is there. Whether it gets followed or not is another story. Individuals with dual diagnosis are also shown to have poorer outcomes, higher treatment costs, greater psychiatric relapse, poverty, marginalisation, stigma, fractured relationships. This has all been documented in the literature, and in 2007 the Victorian state government had a dual diagnosis framework that they put out which sought to make dual diagnosis core business in every mental health service. And again, whether that has happened or not is another story. So I worked in a very busy, probably one of the busiest in Melbourne, inpatient adult mental health units. And I had an opportunity, I wanted to get some community experience, get out of the hospital for a while, to work in an older adult mental health service. And I think it was on my second day I was talking about dual diagnosis, and a clinician colleague of mine, who's actually fantastic, said this to me, and that was the start of my journey into a PhD, looking at this. So it really piqued my interest, and I thought, is this true? How can it be true, really? I've just come from a ward where pretty much everyone seems to use alcohol and other drugs. I mean, I spent probably an hour a day dishing out methadone. We seem to be dealing with ice predominantly, people coming in the back of police divisional vans, being put in seclusion because of their violent behaviour. How can this be possible? And studies in adult populations, there was one done in Thomas Embling, I think about 2005, found 70% of their population, they're a forensic hospital, used alcohol and other drugs on top of their mental illness. So I couldn't believe that I was being told this. So I decided to do an exploratory study and look at what was actually happening. Did we have a dual diagnosis problem? The literature certainly says that it's out there. This is limited in that it's specific to our service, which is the Caulfield Hospital Mobile Age Psychiatry Service. We're a community team that works in the community, obviously, and does outreach work, case management generally, also a little bit of liaison to GPs, nursing homes, and crisis work. We cover the inner southeast metropolitan mental health area, people 65 and over, unless, as I said, they have age-related issues. Then they're we take people a little bit younger. About 265,000 people, almost 35,000 65 and over in, I thought I was going to break it then. In this area, the highlighted area there is our catchment area. Very small, but I've been told it's the most populous out of all of the Victorian mental health catchment areas. Very diverse area. If you're familiar with Victoria, Melbourne especially, you'll see Toorak, South Yarra, Armidale, Glen Iris, Malvern, all areas with median house prices, I think, nudging 2 million plus. St Kilda right in the middle of it, which is a home of a hotel called the Gatwick, which is a notorious hotel it's more of a boarding house, I suppose. In the media, it's had a number of stabbings. I think they had 7 in about 3 years, and a police shooting. It's generally acknowledged that people get released from jail and they'll go there. It's pretty much a hotbed of drug dealing, drug use. Rowe in 2003 did a study on St Kilda, which led to Salvation Army's Access Health program, which is a drop-in GP service, a needle exchange and a crisis housing service, and considered it one of the hotspots of heroin use and dealing in the late 90s, along with Richmond and Russell Street in the city. Also have Port Melbourne there, which has got a high proportion of commission houses, but this housing commission, obviously there's gentrifications taking place and they're changing, but St Kilda's pretty resistant to this. It still has a rather transient population of people with mental health problems, a lot of boarding houses, a lot of housing commission accommodation, and a lot of backpackers. So the first stage of this project to explore this, I looked at the assessments conducted by the clinicians in the service over 2 years. It was 593 of them. These were electronically entered, and I'll just put a little caveat on it. There's no screening tool in this mental health service for alcohol and drug use whatsoever. So I'm really relying on people's, I suppose, interest in whether they want to ask whether people use alcohol and other drugs, which is probably in itself kind of bizarre in this day and age. So 15.5% of people that presented to the service had alcohol or other drug use. So 92 people over the 2-year period. Not only was there no screening tool, but clinicians could enter in their assessment, basically type in, I suppose, free text you'd call it, about what they were assessing, what they saw, as well as a tick box for alcohol and other drug use. And there was a very poor understanding of alcohol guidelines especially. You'd have people where there'd be a narrative entered that they drank 4 glasses of wine a night, but no real issues with alcohol or drug use. Also no planning from the outset as to whether we're going to refer on to alcohol and other drug services or treatment plans for alcohol and other drugs. So this is what they used. Split into males and females. Males are blue, predominantly drinkers. The females were drinkers as well, but also tended more towards polysubstance use. So this kind of fits with the literature with this older population using alcohol predominantly, but there were some changes. And people with no other alcohol and drug use in the green, the primary diagnosis on assessment was behavioural and psychological symptoms of dementia. We have a lot of nursing homes. Caulfield Hospital has 4 on site. There's a lot in the Caulfield area itself, so this isn't surprising. We also have a very good nurse practitioner who does this for her bread and butter, really. Goes out and assesses people with behavioural and psychological symptoms of dementia. But the dual diagnosis population, depression, was chiefly what we saw. Now, I'm a clinician, not a statistician, and I've just had to do a statistics subject, and it hurts my head, but for those who like this sort of thing, basically this says that men, young, and they were boozers. And I kind of sit and think about this and wonder, is it that females aren't readily disclosing? Is it the age difference because people who use alcohol and other drugs that present to our service die earlier, or is it because we're seeing that shift of people come through? So after doing a grade dip in drug and alcohol while I was working on that inpatient adult ward, I decided I wanted to go out and see the big wide world of AOD. So I went and worked for Peninsula Health's Older Wiser Lifestyle Service for 6 months. They gave me an opportunity to do a secondment there, which was fantastic. And this is what I experienced. Basically, pretty much everyone I saw there had some form of comorbid mental health issue. Obviously, there's a spectrum, and in dual diagnosis teaching, they talk about a quadrant model where drug and alcohol use and mental health sort of work on this dynamic spectrum. But I found basically that the collaboration between the service, AOD service, and the mental health team down there was quite poor. And this is a cartoon from the NHS that shows the Great Divide, and this is homeless services and hospitals. But this is exactly how I felt. I felt I was staring back at mental health services. I thought I was pretty good at talking to everyone as a mental health nurse. I thought we all were, but I was quite wrong. So, as a case example, I had a gentleman who I was seeing through the drug and alcohol service. He lived on a rather large property in rural Mornington Peninsula in Victoria. I think it was about 5 acres. And drank quite heavily. He also had a diagnosis. Well, he'd been through a number. He'd been through bipolar, schizoaffective, schizophrenia, borderline personality disorder. But basically, he was quite brittle in that he would become manic very quickly and drink a lot of alcohol, and litres of spirits a day were not uncommon. And he had a number of risky behaviours. Driving, he would start his chainsaw and go and cut down trees about that big while he was drunk. So the mental health team were involved, and I thought they'd be really interested in this because he's quite risky, and to me that doesn't sit comfortably. And working in mental health, I think if something doesn't sit comfortably, I want to be on top of it. I want to assess it because they never have good outcomes when they don't sit comfortably. That's my experience. And they didn't want to know. I sat in with a review with a junior registrar there who basically said to him in front of me, if you stop drinking, this will stop. And it just blew my mind that attitude still persists in mental health services. Again, limited to this mental health service. I hope it doesn't happen in all of them. So the implications for services that I've discovered through looking at this is really this population has been labelled as the invisible addicts by a College of Psychiatrists report in London. And I think to really capture and assess better, we need to expand to the primary care and hospital settings. We need to have good relationships with GPs that are seeing these people who are in a position to make good assessments. Incidental findings of alcohol and drug use are going to happen in hospitals. Our mental health service is based on a big hospital, and they see a lot of alcohol use, and again, they don't refer on. I think harm reduction as well, I'll talk about that a bit more. needs a little bit of tweaking for this population. Our assessment needs to get better, and there's obviously issues with the treatment settings. I'll get to that more. So people with AOD problems and dual diagnosis may not present via traditional means, and this was certainly the case I discovered working at Peninsula Health. We'd often get referrals from the general hospital, from GPs. It wasn't often that someone would ring and say, I need help with my alcohol and drug use in this population. There's been a lot of work by Rosen especially, who has done a lot on stigma and its deterring help-seeking behaviour, more so mental health problems, stigma of ageing, the stigma of chronic illness. These are all things that combine to deter help-seeking. Really, what I'm trying to say, I suppose, is we need a more sensitive, non-judgmental approach, and I'm preaching to the converted, I know, but we really need to kind of model this behaviour to our clinician colleagues that work in primary care and general hospital. And you see a number of people coming into hospital that have incidental finding of their alcohol and other drug use. Before I got into mental health, I was a general nurse. Before I escaped general nursing, I should say. And I worked on a busy trauma ward. And I'd been doing it for about 3 months. And I had this gentleman come in who'd had a fall and had a collar on his neck to keep him immobile. Basically, there were concerns that he had broken his neck. And he was all over the place. They thought it was delirium until 3 days later his son came in and said, he drinks X amount a day, and it was a significant amount. He'd been given some intravenous morphine, and he was very difficult to manage. And it wasn't until it all came together with the collateral from the family that we discovered that was the issue. We're trying to get some funding at the moment, me and my co-authors, to explore in Caulfield Hospital a small project with the nurses on the ward where they can do a very quick screen and refer on to our mental health service for brief intervention and referral for more intensive treatment. Hopefully that gets off the ground, and it will be good to compare it to what we heard in the keynote earlier and see if we can get a similar kind of treatment results. So harm reduction, it's largely geared towards an injecting drug-using population, and it's been a fantastic success. It's saved a lot of money, it's saved a lot of lives. I think it really needs to change in older adults though. And again, this is my experience working for Peninsula Health. Sorry, I've gone one too far. When I say drink driving, I briefly case manage a gentleman who drank a bottle of scotch an afternoon, and when you look at the physiological changes in older adults, they don't metabolise alcohol as well. And he turned around and said to me, but I only drive in the morning. And for a little kind of, experiment, I suppose, with him, I took the breathalyzer and said, well, if you only drive in the morning, surely you're under. And he was over. He was 0.07. So he was doing this every day. And I've kind of brought it up with a few other consumers in AOD and mental health, and they're often surprised that this could be a possibility. And I know it was sort of an education thing not long ago in the younger population, but the older adults seem to think they'll be right, but it's not often the case. Prescription medication misuse. There's a lot of literature out there that suggests, I think around 40% in the States of people on psychotropic medication are drinking to excessive levels or risky levels. Obviously, it has an effect on their cognition and increases their risk of falling. Falls are definitely a big issue in this population, along with other health complications. Also vulnerability, financial generally. I case manage another gent, just to bring another clinical example into it, who has bipolar disorder, and sort of every 6 months or so, he'll have a really intense manic episode. He'll go and use ice intravenously for about a month. He's 72. And through this, he will grab this string of St Kilda hangers-on who will basically extort him for every last dollar he's got, stay in his house, tell him they've got these grand business plans, he only needs to invest $500, and because his judgment goes, he coughs up all his money. He's moved flats twice. The first one had a $10,000 cleaning bill from the damage they'd done to it. So it's definitely something to think about. As well, there's some work in the UK on alcohol where they found that older adults were sending people out to buy alcohol for them And they were generally saying, well, give me £50 when the alcohol cost £10, pocketing the change, that sort of thing. So there's all sorts of issues with identifying this population. Again, they were defined as hidden addicts, hidden population. These results speak for themselves. The 95 study, 1% of elderly women, but I think this one speaks to me more, the 2005. A psychiatric unit with no documentation about drug and alcohol history, that doesn't really sit right with me, because it's generally a very telling part of the assessment, drug and alcohol history, and it's very important. And just to bring it back, we found 15.5% in my study. In the States, they did a much more robust methodology and looked over the notes, then did an assessment later, and they found nearly 40% of people with dual diagnosis, older adults. Apologies to anyone here who's in the 60% of people who dislike this man. That's from the polls too, not from me. But again, I know this has been talked about a lot at this conference, and I can't really add anything from Professor Sandra Jones's excellent talk about this on The Conversation. It's worth a read. But this is really where the funding and everything is being directed at the moment. The attention, I suppose. ICE is a very political issue, and we have one ICE user in our service. And I also worry that it blinkers general nurses who are working in hospital settings, mental health nurses. They're all looking for the ICE user who's going to cause them the most trouble, basically. Whereas, really, in older adults, we want the depressed alcoholic that's hard to assess. And just to kind of talk about how much different they are. I found this on the Wall Street Journal when I was lost on the internet one evening preparing this. This is a 58-year-old gentleman named Mike Massey, and there was an article on baby boomers, drug and alcohol use. Mike Massey's obviously successful, as you can tell by his Gibson Les Paul. It took my younger brother 2 years to save up for one of those, so I know they're expensive. He was played in a rock band in his 20s, he says in this article, and he was pretty open about using a bit of marijuana, a bit of cocaine, but he gave it up by his 30s, Winnick's maturing out, I suppose you could call it, until in his 50s he had injured his knee while he was running, and he was prescribed opiate pain relief. And in his words, he said, it felt like getting loaded again. Basically, he was using over-the-counter codeine, I think, with paracetamol, 40 tablets a day, to the point where he turned up at work affected, and they gave him an ultimatum, go to rehab or else. That was age 50, he's now 58. Also describes having depressed mood over that time. So this is the kind of person that baby boomers, the kind of presentation we're going to get from our baby boomers. And again, our assessment needs to be dynamic. Screening tools are great, but clinicians, we've all got great clinical judgment and we need to use it. If something doesn't sit right, we really need to follow it up. And obviously role model that to people who don't work in drug and alcohol services that may come across this, and really kind of foster that engagement and referral. We need to screen everyone, that's the point there, without exception. At least ask the question. I presented this not long ago in Singapore, last month actually, at a general nursing conference, and they all glazed over as if to say, do we have to? We've got enough paperwork and we've got intravenous drips to check and that sort of thing. But it's a simple question, really, and it needs to be asked of everyone. We've seen the stigma, the judgmental attitudes and what it does, so I think it's important that we are asking and telling people to ask. And just on the treatment settings, I saw a gentleman who drank 24 beers a day and a gram of cannabis, and he wanted to stop. He had tried to stop 3 times, and his partner had said to him, if you don't stop, you're out of the house. So this was his last chance. I suggested to him that he maybe try detox and then go off to a rehab, and this is what he said to me. I've heard that it's full of ice addicts, and they're really violent, and I don't want to be mixed up in that crowd. I also helped a gentleman who drank about 12 stubbies a day go into detox, and he vividly described to me how 2 ice addicts fought in front of him and how really he wasn't that bad and was going to keep drinking. So I think we need some thought into our treatment settings. Again, they're not appropriate to the older adult population, and community treatment is great, but there's going to be situations. I mean, I assessed a lady in a nursing home who was drinking 2 litres of wine a day, still is, and she wants to stop. She's basically palliative and has a lot of medical issues going on, and she's going to need basically a hospital admission for detox because I can't get her into any detox settings. They don't have that kind of medical ability if anything goes wrong, so they knock her back. So we really need to put some thought into our treatment settings. And this last point, I think the Queensland system becoming more integrated is fantastic, and we definitely need to do this in Victoria and definitely in this cohort. Working closely together to offer integrated care. I mean, the literature in the States shows integrated care to be the way to go. This population is no different. We're fragmented. In Victoria, we have one older adult treatment service, which is the one at Peninsula Health for drug and alcohol. They cover a defined catchment area, which is quite far from us, so we can't access them. We really need to expand and look into how we're going to do this. And also supported linkages back to AOD services. We don't talk to them in our catchment area. It's unbelievable. When you talk to them informally, they're telling us that they're seeing a lot of people 60, 65 and over, but they feel that there's a barrier between them and us, and they find it hard to refer. And that's me. Thank you.